Hi, everybody. Thank you very much for joining tonight's presentation. I think people are still slowly coming in, but everybody's almost here. We have about 57 people here. I am recording this, and as always, if you weren't involved before, we will be posting this on a Google Drive after. And then, especially this one, I'm totally comfortable if you guys want to share this with other members of your coaching staff or any trainers that maybe couldn't make it, athletic therapists, or even parents who maybe be just filling a role on a minor football team. This is going to be very detailed, very in depth. I've seen her PowerPoint. It's all about football and injuries. And Nicole McLean is here from Football Alberta, also the Edmonton Wildcats. I did have to apologize. I wrote in the email Edmonton Huskies. Sorry, Nicole. Sorry, Coach Park. It's a bad typo on my part, but Nicole is here. Nicole, you can share your screen and start when you're ready. If you guys are new and this is your first session, feel free to ask questions on the chat bar on the side. I'll also leave my cell number here if you guys want to text me as well. And I don't mind interrupting Nicole here and there throughout the presentation. She'll also stick around at the end and answer any questions. But feel free to ask questions throughout. It'll give us a little bit of a break and give Nicole a break and answer some questions. So I hope you enjoy. Nicole, it's all yours. I'm going to kind of check out, but I will be here throughout and interrupt you as needed.
Okay. There we go. So yeah, thanks for the introduction, Taylor. I'm Nicole McLean. Just my title's there, Certified Athletic Therapist. So if you're wondering who these people are that are running onto the fields with Football Alberta and with all the CGFL teams really in the Prairie Football Conference, we're certified athletic therapists. Also, in addition, I have a sport concussion background. I did my master's in sport concussion research with the University of Alberta and their varsity athletes. So I will talk about sport concussion at the end. I don't know if I can do a football injuries talk and not talk about sport concussions. There's the only action shot I could find of myself today, and I kind of like this one. It's taken in the football Wildcats clubhouse, and we're fitting a brace, and there's my 2-year-old daughter trying to help us. She's copying everything I do, of course. I usually talk, when I start athletic therapy talks and safety in football and safety in sport, this is kind of all the different paperwork that we would go through. We go through preseason medicals, and with Football Alberta for our camps, we had our super weekend, which we were able to get in January. 300 plus kids that are trying out, and we go through medical histories for all of those athletes. We do that online, which makes things really convenient, and there's an app and stuff. We have to go through insurance. But I feel like in this post-COVID world, post-pandemic world, some of this stuff's going to change. So I didn't really want to talk about it a ton today and then have it be irrelevant in a couple months' time. So we can maybe circle back to that come fall. So here's the common football injuries I'm going to talk about. I mean, in football, in a contact sport, I've kind of seen a ton of stuff. I think one of the tweets that went out said I've been working 12 years with Football Alberta. Well, I started in 2003. So it's a couple more years than 12, but that's okay. And you see a lot of stuff. So these are sort of the big things I see, or what I'm going to see every single season. And so, yeah, let's start talking about them. I've taken these slides from a textbook I taught at the university, and I taught their introduction to sports injuries. So this will have a lot of anatomy in it, but I'll help break it down for you guys. So with the ankle, we're trying to prevent movement side to side. So it's really nice when we're running a straight line and our ankle is, we're pointing our toes and pulling our toes up towards our shin. That's the way we want our ankle to move when we're running. When we get too much movement side to side, which is that inversion and eversion, that's when we start to get into injuries. So our most common ankle injury is going to be an injury to the outside of our ankle, or the lateral side of our ankle. And I mean, there's no test here. I just wanted to show you a picture of those ligaments that are usually injured. So let me see my mouse here. These lateral collateral ligaments are the ones on the outside of the ankle. That's that posterior talofibular, calcaneal fibular, and anterior talofibular. This is when you roll your foot so that the sole of your foot faces the other leg. So that you're going to damage those outside ligaments, and you're going to see that ball of swelling right at the bottom of the ankle on the outside of the foot. And this is what we get if we came down sort of on a pointed toe, which we usually do in sport. We're jumping up for a ball. We come down on our tippy toes when our ankle's not very stable, and we roll so that that sole of our foot faces the other leg. And these are the 3 ligaments that we will start to damage if we do that mechanism of injury.
And Nicole, they can see your mouse, so yeah, you're
Okay,
good to
good.
go. Yeah.
And right here is where you will start to get that pocket of swelling right at the bottom of that fibula, so bottom of the bone there. Conversely, so to sprain the inside of our ankle is more difficult. So while you're just sitting here, you can see if you roll your foot, if you roll your ankle, you can roll the sole of your foot to face the other leg quite easily. If you try to roll the sole of your foot out, it just doesn't happen. And that's due to some of the bony blocks in your ankle. If we try to roll our foot outwards, our fibula, that bone on the outside of our leg, is longer and it jams into the side of our foot, so it just doesn't happen. We also have this deltoid ligament here, which is on the inside of our ankle, which is a lot stronger than those ones in the last slide, which were kind of like the width of a pencil. These guys are really thick ligaments, so they're harder to injure. But when we do injure them, it becomes more of a significant injury. So that lateral ankle sprain, another word, inversion ankle sprain, that's just that motion that your foot's going in. That's what we're going to see 90 to 95% of the time. So when I see an athlete go over on their ankle and they come limping over to me, I mean, as soon as I take their shoe and sock off, that I'm looking for swelling on the outside of your foot, because that's what's sort of most common. That's what I'm going to see 9 times out of 10 for my athletes. And there's that list of ligaments that can be injured. When we injure an ankle, or when we injure these ligaments, it's called a sprain. So sometimes you'll hear athletes say, I tore this, or I blew this out. If we injure an ligament, any ligament in the body, it's called a sprain. And that mechanism, again, is usually coming up, or is usually in that plantar flex. So plantar flex is up on your tiptoes. I always tell my daughter, like, pretend you have ballet feet. So you're up on your tiptoes, and then you internally rotate, or that sole of your foot goes towards the other side. A couple pictures there. Hopefully someone's not reefing on your ankle, but that's those ligaments on the outside of the foot getting damaged. And then just an x-ray. Often they'll do x-rays under stress to determine how much damage there is to those ligaments. When we talk about sprains, we get 1st-degree sprains, 2nd-degree sprains, and 3rd-degree sprains. So in a 1st-degree sprain, we get stretching of the ligaments. In a 2nd-degree sprain, we start to get tearing of a ligament. And then a 3rd degree, we have a full rupture of the ligament. So like the picture here where that hand is grabbing the foot, that's a 3rd-degree sprain. We've torn the ligaments, and that joint is going to be very disrupted. If we had an x-ray of it, it would look like this. So I wanted to talk about these injuries. One, if you're out at a football field by yourself, you're a coach, you're a parent, you're a therapist, a volunteer therapist, why we want to talk about these. So a 1st-degree sprain of any joint is going to be pretty stable still, right? We didn't tear the ligaments, we just stretched it. A 1st-degree sprain of an ankle is usually something that as a therapist we can tape up and get our athletes back in. When we start to get 2nd-degree sprains, when we start to get or have a 3rd, those are the ones that aren't safe to get to tape and put back in. So when I have an athlete that comes over to me on the sideline and I take their shoe and sock off, I'll see that swelling on the outside of their foot, and I start to check how strong their foot is. So usually an athlete can stand and do toe raises, like stand up on their toes for me, and now I know that they need to be able to run and cut and change directions. So even before I would try and tape it, I would try and get them to do a little bit of movement. I mean, this is if they're comfortable. If they're hobbling on one leg and limping and can't put any weight on it, then that's not something I'm taping. But if they are trying to do a little bit of jogging, that's when I might try to get them to do some lateral movement, some cariokas before I put that tape on. And if they can't do it without the tape's not going to make it stronger. It's not going to hold the joint together well enough for you that they can continue to play. And I mean, that's when I start to have that talk with the athlete, like, are you going to be effective in your position if you have this sprain, or can we put somebody else in that can not get beat on a pass? Yeah, so that's what I want to talk about, the ankle with that lateral sprain. Well, the other thing I wanted to kind of talk about some of the, errors that I've made throughout football life, I guess. Um, and we've had playoff games. I've had fifth-year athletes. So in junior football, they can play 5 years max. And it's always in that fifth year, someone gets a bad ankle sprain and they say, tape it up, tape anything, tape as much tape as you can to it. And so you've probably seen, like, we'll tape right to an athlete's skin. We'll put a brace on top of that tape. We can spat over top of their shoe, but eventually something's going to give. So if that's a second-degree ankle sprain where they've had some ligament tearing, or a third degree where they don't have enough stability in that ankle, and I still try and tape it, I've seen athletes then hurt their knee. So we make that foot so stable that it doesn't move. But then when their body's going to give, they're going to sprain something higher up the chain. So they might sprain their knee, they might hurt another joint in their body. So, if they don't have the strength on it, it's not safe to tape. And I've made that error, and I've had athletes hurt their knees because of it. The eversion ankle sprains, not as common. I always talk about this in a lecture, and when I taught sports injury, and we're talking about every different sport. In football, I seem to see these quite a bit because kind of anything can happen when you have tackle football. You can have a running back, excuse me, at the bottom of a pile who gets their foot tweaked on or stepped on. You can rotate your foot in those other directions. So again, this eversion sprain, tough to do. This is like rolling your foot so the sole of your foot faces away from your body. There's that bony protection. You jam your foot into your fibula. So you jam your foot into that outside shin bone. And often you can have a fracture of that fibula as well. So you can see these muscles or these ligaments on the inside of the foot. So on the big toe side of the foot that are torn. But this is, you can break the bone. I don't know there's my picture. So in the fibula here, you can break the bone on the outside of your leg as well if you go over far enough. So that's something to watch for with these ankle sprains. If you're seeing swelling on the inside of the foot, then you know there's a bigger structure that was damaged. There could be potential to have that bony break on the outside of the foot. And these ones are tougher to sort of tape up and rush back into sport. So my lateral sprains, the ones we talked about in the last slide, usually we can get those back in quicker, like 2 to 3 week scenario. An eversion sprain, I've even known our sport medicine docs to put them in boots. So an air boot, sort of like to cast it to help the ligaments to heal, because it is such a big structure and you need that support on the inside of your foot. As a coach or a therapist, you've probably heard about high ankle sprains before. I know my husband with his fantasy team, once he had a player that was like, oh, this guy had a high ankle sprain. And I was like, he's not going to be in for weeks. So this is bad for your fantasy team. High ankle sprains are very serious. Again, there's always a mechanism. There's the textbook mechanism. So you kind of torque on a planted foot. You might fall back with your foot trapped underneath your body. What's happening is you're actually jamming your foot into your shin, and it's like the two shin bones are separating. So there's a ligament that keeps your two shin bones together at the bottom of your ankle, and you've started to separate that. And you can see from the pictures here, you get a ton of bruising, a ton of swelling. It's a very severe injury, and this is one that we're not usually back in 2 to 3 weeks. This will be more of a 4 to 6 week one. Often we have crutches involved and boots involved in these as well. So, the bruising and swelling of this has been a couple days, but often as soon as we get an athlete off the field and take their shoe and sock off, we'll start to see quite a bit of swelling right away. And with this, you start to get swelling everywhere. So it's not like that lateral sprain where there's just swelling on the outside of the body. It's kind of swelling the whole way around the ankle, and it's quite a bit higher up. It'll start being swollen up into the shin as well. You can see those messy ankles there. You often have multiple structures that are injured. So you're going to be separating that shin bone, but also have those ligaments on the outside of the ankle that we showed before. Lots of pain here, loss of function. So this is not going to be one an athlete's going to try and run on the sideline and get back into play. This one is going to be where they're hobbling off, and you can see like the swelling all the way into the foot. So a lot of our management with this one is just going to be trying to get that swelling out. Whereas with my lateral ankle sprain or my medial ankle sprain, often we're trying to do some return to play stuff and jogging with our athletes within a week or two. And usually these high ankle sprains, we're just trying to get the swelling and bruising out. So determining that extent of injury as an athletic therapist, we always talk about not making the injury more severe. And I think that's important for coaches and parents and volunteer therapists as well. So swelling is not always a great indicator of how severe it is. If an athlete sprained their ankle before, they might not get a lot of swelling. Some people swell more than others. So, I mean, with that first degree, usually there's little pain with it because there is just the stretching of the ligaments. That's where they're more stable. They could be doing some running on the sideline. You could try taping it up and have some success with that. The second degree, there'll be more pain with it. They'll have less strength in that one. And then that third degree, you're probably going to get some swelling with this one, and it's going to be unstable. So as they try to run, it'll probably just sort of buckle underneath them. The thing with a fracture is it doesn't necessarily have to have more swelling if they break the bone. The pain is acute though, so pain just started. Acute just means it started right away. They might not be able to weight bear. They might be with the fibula by itself. You can still weight bear. So I mean, it's a tough thing to assess on the sideline, and that's why we have X-rays, and that's where we refer them to emergency rooms. A horseshoe pad here. So to try and control some of that swelling, we'll often wrap them in a tensor, these ankle sprains. So now we've determined they can't return to play on this. They can't run on it. We're just going to wrap it up for them. I would apply a tensor from the toes up. So we're always trying to work against gravity. So if you're putting compression on somebody, that's a good thing to know, is we're working against gravity. If we just let this athlete sit on the bench and their foot's dangling on the ground by the end of that game or practice where they're just watching with injury, they're going to have fat, swollen toes. So we like to rice, we like to apply ice, we like to compress it with that tensor against gravity and then elevate as much as we can. And in the picture here, I just have a horseshoe pad. I have some medical foam that I use to make these, but I've also bought like the sleeping mattresses that you take camping from Canadian Tire. I've used those to make these as well. We don't let athletes sleep with compression on, so we don't sleep with a tensor on just because you can't feel if you're kind of cutting off circulation. But I've told athletes to sleep with like a pillow in their bed, even if they just prop their foot up that much with a pillow, that a little bit of elevation will help them. We want to protect it. So I don't always give crutches for a first or second degree ankle sprain, but somebody that was complaining like their ankles collapsing on them, that's where we would look into doing crutches. And if we are returning with tape, if we're trying to return that first degree, it didn't swell a lot, they have good strength, they're trying to run on it, that's where we'll tape it. And just to remember that it's very easy to sprain your ankle while rolling your foot towards your other sole. So when we're rolling the sole of your foot towards your other leg. So when you're taping it, you're always taping it away from that direction. Injuries to the toe. So turf toe, I didn't want to talk about it for a ton of time, but you've probably heard about turf toe in football. So this is basically spraining your toe. So there's ligaments in your toe that hold the joints together, just like any other joint in your body. The ligaments hold them together, and it's like your toe gets stuck underneath your body. You're pushing off and your toe gets stuck under. It's very painful and it's frustrating because athletes are like, well, it's just my big toe, but you need to have a lot of strength and a lot of push off through that big toe. There's different taping techniques where you try to tape the toe up. I usually don't have a lot of success with that. It's one of these where we're icing it for a couple of days and they might need to take a practice or two off to get through that injury. Stiffer shoes or even trying to put some foam underneath the toe sometimes helps, just to support that darn toe. The knee, so knee is a pretty complex joint. Again, we're going through these things pretty quickly. Knee, just like the ankle, it likes to hinge. It likes to go forward and backwards. So that's your flexion extension. It doesn't like to go sideways. So we get a little bit of rotation in the knee, but we don't bend side to side, or then you need us. So this is just an interior view of the knee. They've taken the kneecap off. So the important thing in this picture is this ACL. And that's where what we hear about in sport all the time. We had 3 ACL tears with the Edmonton Wildcats this year, which is really frustrating because or full ACL sprains. So these 3 that required surgery. And in Alberta, that's usually you lose a season because we don't get surgery very quickly. This is like you took your thigh bone off, and this is looking at your shin and where your leg sits. And the picture, why I like this picture is just showing that meniscus. So if you've ever heard about a meniscal injury or cartilage injury in the knee, that's these halves. Circles or these like C-shaped pieces inside the knee. And when they're intact, it gives you some good cushioning, your leg fits together well, you don't have any of that excessive rotation or movement side to side. But you can imagine if these have a tear in them or a crack in them, how painful that's going to be, because now it's like the weight of our thighs on a damaged structure. So our MCL, or medial collateral ligament sprain, is a really common injury for our linemen. So you getting a direct blow from the outside of your leg. So an athlete is planted, they're engaged, they probably have their arms on another athlete, and somebody sort of takes them out. So that's like those chop blocks, midfield kind of stuff. But obviously it happens on the line a lot as well. And this is why you see so many collegiate athletes or university athletes that wear double knee braces, and these are the ones they're trying to prevent. And I've talked about that grade 1, grade 2, grade 3. It's the same level of injury in the knee as it is in the ankle. And in grade 1, we have some ligaments that are stretched. Grade 2, we start to tear. In grade 3, we have that full tear. The nice thing about the MCL is it heals very well without surgery. So it's a big, wide ligament, just like that medial side or the inside of our ankle. And usually with a brace, these ones heal without any surgical repair. Actually, I don't know any of our athletes that have had an MCL repair. But this is usually where we go when we have an athlete that's been confirmed to have that full third-degree injury, and we'll go to healthcare solutions and get them a brace off the counter or off the shelf. And these braces are about, I think last year an athlete got one for about $750. So they're not cheap. And this is that's that force from the outside. So it's really an unprotected position. Your foot's planted, you can't prevent it, obviously. You can't see what's happening, and you get that MCL damage. So in this picture would be like a grade 2, and then this picture has a grade 3, where you'd have that full opening of the knee joint. That ACL, I mean, sort of the textbook example is an athlete comes down on their knee and they plant and twist, and they can do this all by themselves and nobody has to touch them, and they can tear an ACL, and it's really frustrating if that knee just collapses. Often an athlete will talk about a shift or a pop. We kind of talk about like turf monsters, and I've had athletes do this at practice, and I've had athletes do this at games, and nobody's touched them, and it's just they come down on an unstable knee and it just buckles underneath them. It can happen through contact as well, and that's where the bracing will help. If you have a brace on and you get hit, you're less likely to have that ligament injury. But with these poor ACLs, if you have a brace on, everything's happening underneath the skin, underneath the muscles, inside the joint, and you can still have a ligament injury with an ACL in a brace. And these ones, like I said, need reconstructive surgery to be reattached. So the MCL is outside of the joint and it's a wide ligament and it heals really well. That ACL is underneath the kneecap. There's blood and joint fluids involved, and they don't scar down and they don't reattach. So this is where our orthopedic surgeons come in. The ACLs as well, we used to have, say it was a 12-month return to play for rehabilitation, and now they're often 18 months before athletes are coming back to us. The rehabs are really good. A lot of clinics are having sort of, once you've finished your in-clinic portion, you can go to more of a gym facility, and that's where you need to start to doing your sprinting and your plyometrics and some of your bigger exercises. But yeah, like at 6 months, you're not ready to go anymore. It's a good year, 18 months before they want those ACLs returning to play. And in the textbook, I always told my students in the textbook, we break it down and we say, this is a ligament injury and this is a meniscus injury. But often with a knee, and especially in football, we get multiple structures injured. So our surgeons go in to do surgery and they'll see that there's also meniscus damage or there's another ligament damage. And they'll fix all of it while they're there. A knee-on-knee injury would be another example of damaging that that ACL. So that would be more your contact. You can come down from a jump and have the turf monster injury, or you can have that knee-on-knee injury. The meniscus, so I showed you that picture. There's those half C's of cartilage. When I first started working football, I know we kind of talked about one of our coaches that worked with Edmonton Wildcats, our old head coach. He'd had so many knee injuries and they used to take these completely out. So if you tore your meniscus and it was a piece of cartilage that was stuck inside the knee joint. They were like, oh, let's just take these out. And then you're just working with bone on bone, and people got really arthritic. And now all these old coaches need double knee replacements. So now they're tending to try to repair them. They're not taking as much out. They do these arthroscopic surgeries where they go in with the lasers, and athletes can be back in 10 days when they repair these. But they're really frustrating that they're often a recurrent injury. So even after an arthroscopic surgery, we've had athletes that have a second injury to that. If an athlete has locking in their knee, if they feel like their knee gets stuck, that's often because there's a piece of cartilage that's stuck inside that joint. So there's just different ways that the cartilage can tear, and these smaller injuries are going to cause less problems for your athletes when you start to get, they call them bucket handled tears, and there's different names for that. When you start to get a bigger piece of cartilage stuck in your knee, that's when they lock, and that's when your athlete's going to have less success returning to sport. Often with our meniscal injuries, we try to finish the season with them. Again, in Alberta, we don't get orthopedic surgeries the next day. So our athletes try to return that season, and we work on range of motion, and we get them running again. And I mean, I've had athletes return, and then, you know, like 2 weeks later it comes back, or 3 weeks later it comes back, just because that darn cartilage is still torn inside the knee. Cartilage doesn't have a great blood supply, so it doesn't heal on its own. Ligaments heal well, muscles heal better. Cartilage, no blood supply. Once you tear that meniscus in your knee, it is torn. We often see swelling with this as well. So with the knees, I'm cautious when I see an athlete get hurt that day. I'll assess it. I'll write down in my notes what I think they did. And then we kind of wait to see the next day how much swelling there is, to see sort of to assess a little bit more how badly it is. I mean, if we get no swelling, then we didn't tear things and damage things. If we're getting swelling in the knee, we've done some damage. So now we're going to look at hamstring strains. Just checking my time. Okay, we're good. Lots of muscles in the body, and lots of muscles that you can damage playing football. Hamstrings are our orthopedic surgeon at the U of A used to say they're the single most costly injury for NFL players. So in terms of time loss injuries, they have more athletes in the NFL have hamstring strains that keep them out than any other injury. And we'll talk about quadriceps contusions as well. So quadriceps contusions is, I mean, you're wearing thigh pads, but I mean, there's always times when a helmet's going to get there, and a knee and elbow, something's going to compress those muscles into your thigh bone. First degree, you're going to have some bruising. So anytime you damage a muscle, you start to get more bruising. Those ligaments I showed you is kind of that high ankle sprains, that'd be bruising later on. The muscles will be often bruised right away. And hemorrhaging just is bleeding inside the muscle. We're looking for restrictions in range of motions in the muscle injuries. So I'll talk about this with hamstring, and I'll talk about this with quads. Basically, with a quad, it's like I can't bring my heel towards my bum. If I can't stretch out that quad muscle, I've started to do some damage to it. So here's a picture of like a second degree. That's going to be deeper than that first grade. Just like with our sprains to our ligaments in a muscle, we call it a strain. In that first degree, we've just stretched fibers, and that second degree, we start to tear them. And again, it's hard to flex that knee when you have a quadriceps contusion. And then here's a picture of a third degree, and you start to have some more major disabilities. So these are ones that I have athletes that are always trying to push through it. And we massage these, and we heat them up before games, and we try to get them back into sport. So we had an athlete, of course, it's always these fifth-year athletes that get these bad injuries in their last season, and they want to play through anything because they want to play against the Huskies in their last game ever. So we had an athlete a couple years ago that had this quad contusion, and I think he'd missed a game, and then we were trying to get him back. So we were massaging it, stretching it. We had this whole routine to get him into the game, and he played through it, but he ended up tearing his quadricep muscle even worse and was out for the rest of the season. So this is kind of my cautionary tale to you. We think about it, these are just Charlie horses. Another name is a Charlie horse. I just got a bruise. I want to fight through this. Well, these are the ones that we fight through, and it becomes a bigger injury. So this is where we probably needed to take 2 weeks off for this athlete, and he would have been able to play the rest of the season. Instead, he pushed through and made it even worse. Here's the hamstring. So the most expensive injury in NFL football. The hamstring, we've probably all seen it. I see these on like the Friday nights, the testing of the tryout camps. We're running 40s inside the foot dome, and athletes haven't run all winter, and they come up halfway through, or they come up at the end and they're grabbing the back of their thigh. These are really frustrating because there's lots of different reasons why they can happen, and they often come back for our athletes. So I put this supple leopard textbook up here because I've had athletes with our junior team, and I work with them for 5 years, and they get hamstring strains every season. And so we work on a lot of flexibility. We look at strength imbalances. It's a whole sort of investigative reasoning and to figure out why these hamstring strains keep coming back for these athletes. That grade 1, we had some fibers torn. So this is again a big one, or if we're at a grade 1 point, if they have tenderness in that hamstring, if it hurts for them to extend their knee or straighten their leg or stretch that hamstring, we want to back off. So this isn't something we can play through because we're going to make it worse. I often give athletes adjectives. If it's a sharp pain in that muscle, you're making it worse. If it's a dull, achy pain, maybe just as more of a fatigue thing, dehydration thing. If we're getting sharp pains in the back of our hamstring, we're making this worse. So we don't want to go to a second degree injury where we have partial tearing, that bleeding, that big loss of function, or a third degree where we have full tearing, because then we're out for weeks. That grade 1 injury, we could probably get our athlete back in 2 weeks if we fight through it. I have this hamstring injury that bothers you all season, or I have it coming back every season for you. Grade 3 injuries are big. That's that full rupture. With an ACL injury in the knee, they go in and surgically reattach that ligament. A lot of muscles, they don't reattach. So if you tear a hamstring muscle, it's a group of 3 muscles, they don't always get reattached. We had an athlete that was trying out at one of our super weekends, and he'd torn one of his hamstring muscles off of his pelvis where it attached, and his dad actually had the x-ray of the piece of bone inside his hamstring muscle. So midway down the back of his thigh, and that's not something they're surgically going to repair. So eventually, I mean, your hamstring muscle is no longer attached. It's going to atrophy and go away. But that's like a big mass and a big gap in your hamstring, and now you're working with 2 muscles in the back of your leg instead of 3. So probably the most important word on this slide is conservative treatment. If I see an athlete that at a night at practice or at a game that gets a hamstring injury, we put ice on it and we back off that night right away. So it's not something, again, that we want to try and play through, or it's just going to become a bigger injury and something that you're fighting with for longer. Excuse me. Shoulder, again, I mean, I could talk about a ton of injuries in the body. Shoulder, I think something that's really common is going to be that separated shoulder that you've probably heard about. When we separate the shoulder, it's our collarbone or our clavicle is coming away from our scapula or our shoulder blade. So there's a piece of bone on the shoulder blade that comes up the back. That's where our collarbone attaches, and that's this joint that we sprain. Again, in football, we get tackled, anything can happen. If an athlete's by their self and they fall on an outstretched hand or land on their hand, and that force goes up the shoulder, that can separate that joint. Get a hit into the boards in a different sport, get a hit into the ground in football. Some pictures of where that injury would occur. So once you got skin on, what you're looking for. I mean, following the collarbone, and I always just start right at their chest or right at their, why am I losing my anatomy terms today? So I usually start palpating right here, and I go along the clavicle to the scapula, and just, if you palpate this and it is a sprain, it's going to be tender for that athlete. There's not a lot of swelling because it's a small joint. So even with a full injury, there's not going to be like that baseball of swelling we see in the ankle, but we will see like tenderness over top of that joint. So with a 1st degree injury, we don't see a lot of disruption. With a 2nd degree, we start to get tearing, just like any other sprain in our body. 3rd degree, we'd get tearing. That 4th degree, now we can actually get separation of the clavicle from the body. And the 5th degree, you can tear the muscle attachments that attach to that body or to that joint. So what you're looking for here is, again, function. So if I'm looking at a receiver, I want to see that they can lift their arms over their head. I want to see that they can lift their arm across their body. If they can't do that, they're not going to be able to protect themselves or keep themselves safe in that sport. So regardless if it's a grade 1, grade 2, grade 3, how bad it is, if they can't move in this position, they're not going to be able to do their job, but they're also going to just make it worse. So here's some x-rays where you can actually see there's separation there. So here's a good one. You don't want to have all that black space. The bone should be touching that other bone. Again, there's swelling in that area. That it's difficult to lift their arm. If they can't lift their arm through a full range of motion, that right there is a red flag for us therapists that they shouldn't be back in their sport. And often we put a sling on them. So they'll usually put like a dumbbell or a weight in the athlete's hand if they're taking this x-ray so they can find how big this space is. And sometimes they'll have to surgically repair them. I've seen this more lately, even with collarbone fractures, if they break the collarbone. We have an orthopedic surgeon in Edmonton who's doing a lot of these for us right then. In the hand, again, there is a lot of bones in your hand. We could talk about fingers. We could do a whole conversation on just hands. The bone I worry about in the wrist to hand is the scaphoid. So underneath the thumb, where the hand joins the wrist. This is a very common bone to break, and it's an easy one to miss. It doesn't hurt a lot for the athletes, so often athletes don't even realize they've broken it, and they'll just come and ask us to tape their wrist because they say, oh, I felt like I sprained my wrist. I felt like my wrist got pushed too far back. So can you just throw some tape on it? And in the heat of the game, I mean, for a home game with Edmonton Wildcats, we dress 65 athletes. So we've taped these up and then we reassess them later after the game, and our team doc sends them for x-rays. Again, in football, anything can happen. You slam your hand into somebody else's chest, you put your arm down on the ground, and you can fracture that bone. The scary thing with the scaphoid is it has a poor blood supply, so if we don't catch the fracture right away, they often don't heal properly, and I mean, a lot of times they don't heal properly anyways. So we're looking for that pain at the bottom of the thumb where it attaches to the wrist. If they have pain on that thumb side, if it hurts for them to extend their wrist, it hurts for them to bring their thumb down towards their arm, that's something we'd be referring for an x-ray. Here's a good picture of it, so you don't have to look at my hand. So yeah, we're just looking for that pain that's right there at that bottom of the thumb. And you can see here that little red line where that fracture is. If you fracture the bone into 2 equal pieces, it heals quite well, but often it doesn't. You'll get a third and 2/3 fracture, and you don't get great healing. So I've known athletes that have been cast for months while they try to get these to repair themselves before they do surgery. So if it doesn't heal well, worst case scenario is they have to do a bone graft. I've had athletes where they take a piece of bone off their pelvis, so off their iliac crest, or they might take it off your radius, so further up your arm, to repair. So that's something, again, we don't want to have an injury get worse. If we can kind of catch that they got this pain on the thumb side of their hand right away, and send them for an x-ray, less chance that they're going to need surgery. All right, so those were some of the common orthopedic injuries. Now, like I said, I didn't really feel like I could do this talk without talking about concussions. There's different consensus statements that come out every 4 years. So one's due in 2020, actually. Last one was in 2016. But the definition of concussion hasn't changed a lot. So, I mean, this is your textbooky, your scientific paper statement of what a concussion is. An important thing to remember is it can happen if you get a hit anywhere in the body. And in football, like I said, there's often that mechanism. So it's rare that we'll go through a full practice or a full game where somebody doesn't get hit. And even in our non-contact practices or our helmet-only practices, I know a lot of our linemen and a lot of our running backs complain about our helmet-only practices because they say, I'm still getting hit a lot every practice and I just don't have pads on now. It just has to be enough force for your brain to shake inside of your skull. The good thing is it is usually short-lived. So in 80% of the cases, you're better in 2 weeks and you're back to your sport. And it's a functional injury, not a structural injury. So nothing shows up on MRI. Nothing's going to show up on a CT scan. It's going to be a function. It's going to be symptoms that your athlete's complaining about. And they resolve spontaneously. So there's really nothing we can do drug-wise, treatment-wise, that's going to fix the brain. So it results in some of those neuropathological changes. So I just put a picture, like it's at the cellular level of the brain is where they're finding these injuries are happening. So nothing that's going to come up in a hospital setting. It's more of in a research setting that they find these things. Symptoms, I think we're all familiar with the symptoms. We're still using a SCAT-5. That's the most common one out there. Like I said, this concussion in sport group's probably going to come out with another one for 2020. But the SCAT-5, they're free online. You can just Google SCAT-5, and it's about 5-6 pages with lots of different tests you can do. The symptoms are really important. So it gives us more of an objective answer for our athletes of why they're hurt without just making a best guess. It gives me something to write down on a piece of paper. It gives me something to prove to a coach or prove to a parent about what their symptoms are. And it's better than me just asking, how do you feel? So an athlete might say they feel fine. And then when I start to give them this list of pressure in the head or blurred vision or sensitivity to light, they might start saying, oh yeah, I start to feel some of those. So I use the SCAT-5 for assessments on the sideline. Baseline testing, lots of people ask me about baseline testing. There's a lot of companies and a lot of clinics that make money off of baseline testing. And if you have a group that's set up to do that, that's great. We do baseline testing. We've done pen and paper with the SCAT-5 for years at Wildcats. Now, last year, of course, we just had a new app that came, the Prairie Football Conference is using. So that's what we've been using. It does involve more than just the symptom checklist. So it's got some cognitive, some memory, months of the year backwards, those questions that the athletes always hate, and some balance assessment involved. They're really useful, I find, with the athletes I'm working with all season long. So I like to have also that 5-10 minute assessment time or baseline testing time with an athlete so I can remind them what the symptoms are. I can have a conversation about what to do if there is an injury, but they're not necessary to assess a concussion. So with the 300 to 400 athletes that tried out at our super weekend, we don't have baseline tests for all of those athletes. But if an athlete comes up to me on the sideline, they say, I don't feel right, I got hit in the head, I got hit somewhere else in the body, I can still make a clinical decision without a baseline for our athlete. You can also still work with a physician or work for the therapist to return an athlete to play without a baseline. So if you have them, it's great, but it's not the be all and end all. Many athletes don't recognize if they've had a concussion in the past. I think that's getting better because there's so much in the media, and we do this baseline testing. We remind our athletes to be aware of it. You might want to do more of a pre-participation evaluation. So again, that goes back to those medical questions. And I have some examples of those on the next slide. And again, it's that educating the athlete. So if it's football specific, you can ask football specific questions. These were examples of questions we asked the varsity athletes. If they've had previous head injuries, what sport it was in, how many they had, did they have any facial or dental injuries? So if you broke a nose, if you get a hit in the face hard enough to break your nose, there's a good chance that you could also have a head injury with that. Any non-sporting head injuries, car accidents, those kind of things. So again, there's lots of questionnaires out there. There's websites, there's apps that provide these kind of questionnaires as well. It gives you some more information for your athlete. And again, they don't always fill out in the prior medical history of our online medicals that they've had concussions, but if we put that as a separate category, they'll give us more information. Our return to sport, hopefully you guys have seen something like that. So if an athlete is diagnosed with a concussion, we're not returning them to play 24 hours later. So we want our athletes to go through these 6 stages. There should be 24 to 48 hours between each stage. So I know with our varsity athletes or our junior athletes, we go 24 hours between each stage, but when I was doing research at the university and we were working with younger athletes, like under 16, we were going 48 hours between each stage. So younger athletes, brains growing, there's more going on. Just wanted to be more cautious. And I mean, it's great if we can see a physician at stage 1. I mean, textbook says stage 1 and before they return to play. I know that's not usually a possibility. So with asset, when we have a team physician with the Wildcats, and I usually just send them an email to say we went through all of these steps. Now can we return to play? So maybe with this post-COVID world where we have some more of these online accesses to our physicians and our family physicians, maybe we can have some more of those conversations. So the interesting sort of new stuff that's coming out in the literature is that we used to sort of do full rest. We used to say complete rest when an athlete was diagnosed with a concussion. And that was cognitive rest, so no video games, no TV, no reading. And that was physical rest, no going for a run. Now the research is showing that sort of that sitting in a dark room with the lights off doing nothing is really just extending your symptoms. So they talk about symptom limiting activities. So doing some activity that doesn't bring your symptoms back. So often now we recommend to our athletes, like the next day, say they hurt their head Saturday night, we're suspecting a concussion, we send them home with all of the rules that our physician has given them. So no medication, monitoring their concussion, no alcohol, those sort of things. And then the next day I say, get up and go for a light walk or get up and go for a light bike. So not something that raises their heart rate so much that their head is going to hurt, but not just the dark room. And same with a little bit of cognitive stuff. So probably not video games because that's a lot of stress to your brain, but read a book, watch a 20-minute TV show, that kind of stuff, just so that your brain's getting some activity rather than zero activity. So they find, I mean, if we sit a kid at zero activity for 2 weeks, it's hard to get back. We lose fitness. We start to have just more symptoms due to that, due to not having done anything. That's pretty much what I just talked about. And these are the newest consensus guidelines. So the one I pulled up to make these slides, it just came out in January. It's just published in January, and it's American Medical Society of Sports Medicine. I think they're called Medicine 3 times. We return to the classroom as well. So most of the athletes we're working with are also students. So we need to think about adding, building up their classroom work just as much as building up their physical work on the football field. And there's some ideas there. And again, I'm not like a teaching expert, and there's lots of different ways we can add these things in for our athletes. Some of the rehab that's getting more popular is there's often a neck injury involved with the athlete or damage to their balance systems. So that's something where we would send for physical therapy, chiropractic care, working on that upper neck pain. Even myself as an athletic therapist, if our athletes come in and they're complaining about a lot of neck pain, if we can relieve some of that neck pain, it takes away some of their headache pain. So we work on that portion of the symptoms to help with some of their return to play stuff. There's multiple different symptoms and every concussion is a little bit different, but if someone's complaining about a lot of neck pain or balance issues, that's where we would refer them to different therapy. So that's my last slide. Do we have any questions, Taylor?
Yeah, so thank you very much, Nicole. No questions yet, but so at this point, excellent job, Nicole. Thank you very much. Please stick around, you guys. I know I just kind of wanted to maybe ask a question about a lot of these teams and coaches on here are probably high school and minor football, and
yeah,
you deal with, you know, maybe having 2 or 3 professionals on the field during game days. But I'm going to put you on the spot, kind of like, what are some of the most important things to be doing and watching, you know, during game days as a, you know, a sideline athletic therapist? And then while she's answering that, if you guys have any other questions, or if you want to stop sharing your screen, if people want to put their video on and talk directly to Nicole, you're obviously more than welcome. And yeah, I guess, what are some valuable lessons that you've learned about, you know, what do you need to be doing on the sideline? What does game day look like for you?
Yeah, I mean, so I kind of breezed through the beginning, the medical forms and the emergency action plan, but really having an emergency action plan is if I needed to call an ambulance, what are the roles of everyone involved. So in football, fortunately, we don't have to do this very often, but it is having that emergency first aid and being aware about the head and neck injury first. So every time we run out on the field, I usually put a hand on the athlete's chest or a hand on their helmet and talk to them and ask them about head and neck injuries before we start to go, oh, you grabbed your hamstring, or oh, you grabbed your knee. So I didn't even get into that stuff today. But that's, I mean, if you have a volunteer on the sideline, and yes, you're not going to have an athletic therapist, but even having that basic first aid for those significant injuries is important. And then today's focus was, I mean, now we know these orthopedic injuries are going to happen. Which ones can we get forced to play, and which ones are not forced to play, but I know our athletes are always pushing to play. So which ones can we help them with, and which ones do we have to bench them with?
I'm not sure if you can see the chat there, but as a minor coach, what would you recommend for coaches' communication to schools post head injury?
Yeah, so this is a tough one. And we have this at our trials. So we have that super weekend. We have 400 athletes. We have half a dozen get concussions, and then how do we sort of communicate with everybody? So I know when I was talking with our medical supply, or our online medical, we keep track of the injuries. Usually what the varsity teams or the university teams are doing is just sending a note to the parents and sending a note to the coach to say that they suffered a head injury. So we don't even have to go into like what the mechanism was. But getting everyone just to be aware that a head injury happened is important, because we don't want that athlete to kind of hide it so that they can go to gym class or they can go play their other sport, because usually they're playing hockey or lacrosse and stuff at the same time. So with our tryouts, it's easy. We have access to the parents. The parents have to give under 18 athletes permission. So it's probably easiest, I mean, and legal wise, to just send an email to that parent to say that they suffered a head injury. And then, I mean, we put it on the parent to communicate with the school.
Okay, shin splints. What do you recommend for shin splints?
Oh, shin splints are one of those kind of like a hamstring injury where there's it could be a million different causes. So shin splints could be like, it could be improper footwear. It could be tight calves. Often if we have a shin splint, we start taping the arch of their foot. If that works well, we try different insoles for their feet. So without having to do like orthotics and going through prescription, usually I talk about super feet. You can go to like in Edmonton, I send them to United Cycle, like a sports store that sends super. I mean, you can probably go on Amazon and get super feet. So trying an insole on their foot, which will help support their foot and take some pressure off the shins.
Are there any exercises, and if anybody wants to pop their video on or just ask a question, feel free. Are there any exercises that you recommend to players during training off season to help prevent some of the injuries?
So probably the biggest injury prevention programs that you'd see are for ACL injuries. And there's been a ton of work in soccer, because they have a lot of injuries in soccer with ACL injuries. We have them in football too. And there's a lot of athletes that'll put their videos on YouTube. So I often tell my athletes to look, like their favorite NFL players probably got some of his workouts on YouTube. And with that ACL injury, it's a lot of like single leg stuff. So the athletes always like to do like the squats and lunges and trying to get their max weight up. But it is a lot of like a single leg squat, so that we don't have that collapsing of the knee towards the inside of their body. So working on posture and knee stuff.
Before I get to the next question on the chat, is there anybody who wants to ask a question? Just unmute yourself if you want.
I see one question here that talks about, it's going back to concussions, and it's talking about the 6 stages of injuries.
Yeah.
6 stages of return to play. So on that SCAT 5, if you're concerned about sort of teaching the kid and the parent and the teacher the return to play steps, if you print out that SCAT 5, which is a free PDF online, one of the back pages goes through those 6 stages of return to play.
And Football Canada, Football Alberta also has our return to play policy and the stages laid out there. It's on our website.
Yeah.
I could probably email it to you as well. So, do you have any preference for neck exercises, whether for prehab or rehab?
We don't do a lot of like neck prehab, like prevention of injury. There's some research that shows if sort of an athlete like braces for a hit, they can help stop their head from or their brain from moving inside their skull. in football, again, they don't always see it coming. It's more in the rehab stage. It'd be more on working on just like getting that full range of motion. If they have that concussion and they get sort of a whiplash and they don't have like the shoulder check ability, then that's what we're working on to get them back to sport.
Well, my 9-year-old's supposed to be doing math homework, and she's more interested in your sport injury. So maybe she'll follow your footsteps. She loved all your pictures.
There's not a lot of math involved in athletic therapy.
She loved all your pictures. So we will be sharing Nicole's PowerPoint on Google Drive and a recording of this document. So once again, feel free to share her information. Her email was on there. I'm sure she's reachable via email or even phone calls if you wanted. But you read that question there at the bottom, Nicole?
Yeah. Yeah, I mean, if you have a staff member that's not the coach, that's always a good idea to have, especially with someone with some medical background. So I know a lot of teams will use paramedics, nurses, like, I mean, really whoever will volunteer, whoever can help you out. And it's good because then the coach isn't making that injury decision when, I mean, I know my head coaches, they're so busy about like who's supposed to be on the field right now and what down it's on. I mean, you can hardly interrupt them to say somebody's injured. So having someone that doesn't have to worry about that is important. And then you don't get swept up in the excitement of the game. And even myself, like I'm always cheering my teams on, but I have to remember that if this is a 1st-degree hamstring injury and I force this kid to keep playing, he's going to have a more significant injury and we're going to lose him for the next game. And often if I go through that with a coach, they realize, I mean, do we want to risk losing this athlete for the whole or for the whole season to get 15 more minutes out of him? And that's usually a decision the coach and I agree on that. No, we don't want to do that.
What's an absolute must for your trainer or your volunteer parent or whatever during practices to have for supplies during practices and then also during games? What should they have with them?
Yeah, well, I mean, now we always have gloves. So in my pocket, like I carry a fanny pack and I have gloves in there. I have gauze you're going to have bleeding. So I pack it with a lot of gloves and gauze. And then I do have medical tape for taping ankles, but I would think like, first of all, I got to deal with the more significant injury, which would be bleeding. So gloves, your gauze, a pocket mask if you had to do CPR. Fortunately, I've never had to pull that out. I also have emergency shears so I can cut off jerseys if I need to. And I carry all of our helmets are Rydell's and they have the quick release helmet clips so I can take the face mask off really quickly. So I carry that little tool that takes those off really quickly. And then tape's kind of like the last thing I throw in my pocket because tape is something I'd pull someone to the sideline with and assess that ankle a little bit before I had to tape it. But yeah, it's the gloves and the mask and the shears.
Well, Scotty Ledoux, you're our celebrity question every time you seem to pop up on our beautiful screens and say hello and have a really valuable, important question. Do you have any reports?
I probably taped Scotty's ankle at least once.
Hey, Scotty, it's your question of the night.
Ask who your favorite Wildcats lineman of all time was. I'll sign off and wait for the answer.
Did you hear that?
He said something about my favorite alumni. I saw his jerseys in the background.
Oh yeah, caught him going there. Yeah, I don't really have any questions. More learning here. Just saying hello. Good to see you.
Hello.
Perfect. Scotty has a good question every single night, so he kind of disappointed tonight. But if there's any other questions, feel free to jump on. We'll hang out for a moment or two unless we have any other questions.
Just a quick question about Achilles tendon injuries. How often do you see stuff like that happen?
Sorry, it was cutting out.
Kayla, you kind of cut out there, so just maybe speak a little slower.
Sorry, I said for Achilles tendon issues, do you see much of that for damage of Achilles tendons within players in minor football?
I've seen we've had a tear at junior and I've seen a tear at varsity. Fortunately, our younger athletes don't usually have that full Achilles injury yet in life. It happens more at like my husband's old men's basketball. But with the Achilles, I mean, that when you get pain right down at the heel, that's again something we want to be cautious with, just like with our hamstring strain, because if we do continue to push these athletes, they get little tears and then they set themselves later for that bigger injury, usually when they're older, and they have had many tears when they're a younger athlete. So it'd be the same assessment, just like with my other muscle injuries. So with that quad, I wanted to be able to bend the knee. With the hamstring, I want to be able to straighten the knee. With the Achilles, you're trying to bring your foot up to your shin, so that would be the stretch for it. And if it's painful for them to do that, then we've probably done some damage to that muscle, and it's a major muscle group. If you tear it, it's a surgical scenario. So also we want to ease off and be cautious with our athletes. There is a taping technique for Achilles, but trying to tape a muscle doesn't provide a ton of support. So usually when I tape an Achilles is when I've returned someone like 2-3 weeks after their injury.
Okay, I did receive a text and a couple on the chat here, so a couple good questions. Those new neck collars that apparently prevent concussions. What are your thoughts on those? You know the ones I'm talking about? Like
Are they the ones that compress?
Yeah.
Yeah. I mean, I think the idea is they compress to sort of restrict.
Jugular.
Yeah. I haven't had an athlete play with them. Again, the thing you're trying to stop, and which I've gone to lots of different conferences on this, and the sport concussions experts say until we can stop the brain from shaking inside that bony hard skull, we're not going to prevent a concussion. So anything we put on top of it is just sort of added. Your brain's still going to shake inside your skull.
Okay, so while we're talking concussions, there's a question from Ryan about whether you want to bring your slide back up about the active recovery instead of the pure darkroom rest scenario. So how I guess doctors or research has changed a little bit from maybe 5-10 years ago. You go to share screen and then back to your PowerPoint. Or just talk about kind of how maybe research has changed a little.
And so this stuff's pretty new. Like I said, that paper came out in January where this was come out. And this is where they're sort of telling the general public about it. I mean, as therapists, I've seen the research coming with this. And it's not a lot of exercise. So you'd be at that first stage. They're still talking about 24 to 48 hours of full rest. And it's after that. Like if you're still having symptoms, if an athlete came into practice and I had them fill out the SCAT-5 again, and they still had symptoms of like 1s and 2s, my textbook tells me, or my licensing body tells me I can't move them up to a bike, or I can't move them up to that light aerobic exercise, but I could have them do something really easy. So go for that gentle walk or read a book. So that's what we're adding. And we're not adding sport specific stuff. We're not doing drills. It's just that little bit of activity. Like, I mean, we used to tell athletes to stay home from school for 2-3 days. And now this would be, the converse would be like, well, what's that class you really have to go to? Do you have a math exam today? So rather than sitting in a dark room for 2-3 days or a week, let's add a little bit, because we've found that the athletes that do nothing for a week, then their symptoms are just worse when they come out of that dark room.
Can you speak to stingers? What are the precautions needed when putting an athlete back into contact for stingers?
Yeah, so a stinger is, I mean, the nerves that come off of your spinal cord that go to innervate your arm to give you strength and feeling in your arm. When you bend your head to the side, you stretch those nerves. So if someone gets hit and their head goes to the side and their shoulder goes down, they've stretched those nerves. So what we're checking for is that they have full strength and feeling back. The best way to do that is compare both arms. And so there's actually like a level. I mean, you test each nerve, and that's what I would do as an athletic therapist. But really for you, I mean, it's even just like get them to chicken wing and see if they can hold their arms up like that. Get them to see if they can do a bicep curl. Did they have a strong grip? And you want right and left to be the same. And then we even run our fingers like down their arm, and they close their eyes, and we make sure that they have that feeling. So if they don't have full strength and they don't have full feeling, it's not safe to put them back in. But it is a nerve injury. So they tend to be recurrent and they tend to come back. I know our team doc still talks about putting guys in the big cowboy collars when they have them. Usually it's like a linebacker. We put them in a big collar for the rest of the season. And then in the off season, we have to strengthen around their shoulders so that doesn't keep happening.
Okay, really good question. I think for minor football, if you have a parent or somebody who wants to volunteer but has limited experience, what are some steps to get started?
Yeah, so the Sport Medicine Council of Alberta has an athletic injury management course. So it's a weekend-long course. And so I used to teach it. So the first day would be 8 hours of like in-classroom stuff, more detailed than my slide were for sure. And then the second part of the second day would be taping. And then you do a lot of taping. So taking a course like that, I know in Red Deer, There's a clinic there that offers them Mel-Tech. If anybody knows Mel and Red Deer, she offers that class. They offer courses out of Calgary as well. So looking for a course like that. If you didn't have that in your community, even just a first aid, and then getting a basic first aid, and then getting yourself some taping experience.
All right, Nicole, I don't have any other texts, nothing on the chat. So we'll once again just give somebody a minute if they want to pop up and talk directly. If not, we'll wrap it up. I will be posting, as long as it downloads properly and no technical issues, I'll be uploading this to the Google Drive tonight. Another question, no problem. Don't be sorry. That's why we're here. I was just going to ask, do non-coaching volunteers, trainers need to be certified by Football Alberta for minor football? And please send info on the courses. So maybe I'll look up the Sport Medicine Council and see if a link to their website. I'll include the link to the Sport Medicine Council in my recap email, but what kind of certification do we need to be a Football Alberta trainer?
And so, yeah, I mean, that would be sort of your basic first aid, I would say, is the sort of lowest level. So if someone had basic first aid, and then anything on top of that would just be a bonus. And then there's always, of course, there's always separate, what am I trying to say, sport concussion courses. There's always sport concussion courses out there, and they're often free. I think Football Canada is working on one for you guys. So you shouldn't have to pay for a sport concussion course.
Okay. Just some thank yous and great job. No questions, nothing on my phone. Going once. For minor players with injuries that happen on the field, I find the hardest part is identifying the severity of the injury with the kids' different levels of pain tolerance.
My husband's a football coach, and he's like, are you going to tell them about the fakers tonight? I'm like, I mean, my thing is always worrying about the athlete that wants to play through anything. And then is going to play through that quad contusion and then tear it. And it is tough with younger kids that are trying to take a practice off. And we even get it at junior levels, is taking that practice off. So with the pain tolerance is kind of, I mean, as a therapist, I can assess it. So say we're looking at an ankle, you take the shoe and sock off, you start to see swelling. They can't put weight on it. Then you know it's this injury. We need to ice it. We need to take care of it. Pain tolerance is going to be different for everybody. You take the shoe and sock off, nothing's there. Often I put ice on it, and then we can get them back in the next day. You kind of have to treat them all the same until you see how that injury turns out.
All right, and I did a quick little update at the start of yesterday's presentation because people are asking about when can we play football again, what are we doing? We don't have an update at this point. Football Alberta is following all Alberta Health Services regulations, and until those are lifted or until they give us a date we can play again, we are suspended for the time being. So nothing has changed. So the update is stay tuned. We're hoping to get out there. We are putting plans together for hopefully July, if not August or September, but we're all crossing our fingers, hoping that everybody stays healthy and that we can play football again soon. So there's still another question here. Lower back injuries, success on recovery and duration.
So anytime we hit the spine, our worry and our fear is fractures. So we're very cautious with those. I mean, I guess depends on your mechanism. If an athlete's laying on the field, can't get up because his back hurts, that's more of an ambulance call. If an athlete comes up to you for low back pain, there can be a lot of different reasons why their back hurts. And then this is why, even for myself, we refer to different specialists. So often we have to start with our team doc, and maybe x-rays are needed. Maybe we use a chiropractor. And then when they come back to me, it's usually I work on some more strengthening. So the first is to figure out why that they're getting pain there in the first place, and then work on some strengthening core stuff.
Yes. So any other questions, we can direct them directly to Nicole's email. If you guys want to ask questions, I'll include it. It's in the presentation, but I'll also include it in my email tonight. There was one last question on Football Alberta considering lifting restrictions for July football for minor football. As our policy state currently, there's no minor football in July. It's off season. yes, our board is having a meeting next Wednesday night, April 29th, I believe. And one of the agenda items is to discuss lifting the restrictions for July. I'm not going to speak to it any further. We're going to have a discussion where there's going to be a motion if we are lifting it or not. We'll have an update probably May 1st with more updates on that. I would think so. That's about it. I'm going to wrap up the meeting, and I'll download it and post it on the Google Drive. Once again, share this with all your parents, parent volunteers and trainers, and anybody who has an interest in being an athletic therapist or just someone on the sideline. We can't have enough of these people. So thank you again, Nicole, and have a great night.